Family Care. And today we met with a sweet young couple, first-time mama at 36 weeks, to go over our long informed consent conversation, where we go over the risks, the benefits, the alternatives of actually their location of birth. And so for women that birth out of the hospital, there are a lot of discussion points around the safety and the equipment the midwives bring and the risk assessment that we're continuously doing. So with this 36-week visit, we go into all of the complications and how we could possibly handle them. And although they're very low risk and very unlikely, it's good to be prepared for everything. So one of the potential complications is a breech presentation, and this is where the baby's bottom is coming first. I just don't think your baby really has the room to move. Be very, very, very unusual for your baby to flip around. She's kind of wedged in there in that position. But still it's possible, so we'll continue to assess your baby's position at every visit, make sure that she's staying right where she's supposed to, and we'll also assess right when you check in, make sure baby's in the right position. In this area of the country though, a breech presentation cannot be born at the birth center, and so at the hospital all breeches are cesareans. If we had a mild bit of fetal distress, the first thing we do is just move them all, because that could unpinch a cord that's between a bony baby shoulder and a bony maternal pelvis, because the baby moves when mom moves, and so that can resolve that issue. We could also have you breathe oxygen, and we could also have IV fluids run at a very fast rate to help rehydrate your uterus. But if the fetal distress were persistent or severe, that would be a reason to seek medical care, because the baby's probably going to need a higher level of care when he comes out. Yeah. Okay. Sometimes the baby releases meconium into the amniotic fluid. Meconium is the baby's first poop, and it shouldn't be in the amniotic fluid. It should keep it until he comes out. But if it releases it early, sometimes that can spell fetal distress as well. And so that's one of the main reasons why we're so diligent at listening to baby's heart rate before, during, and after contractions every 20 or 30 minutes throughout your whole labor. Because the only way the baby tells us how they're doing is with his heart rate in relation to the change in the uterine environment. So that's why we monitor babies so closely. Prolapse cord is when the cord comes in front of the baby's head, and then every contraction would compress the cord, and that would be a severe issue for baby. So babies with cord prolapse are always born by cesarean to save their lives, essentially. Shoulder dystocia is when the baby's head is born and then its shoulders are kind of stuck behind the pubic bone. Most cases of shoulder dystocia happen because the mom is numb and on her back. And so it changes the shape of your pelvis when you're compressed on your back, and it changes the strength of your muscles when you're numb. And so that's definitely a problem. But if baby's head was born and then the shoulders were not coming easily, the first thing to do is move the mom, because again it moves the baby and widens the pelvic capacity. If that is not successful, then we have actually 12 different hand maneuvers that help to deliver the baby if need be. And so we feel like very skilled to deal with that. We can't go anywhere with the head hanging out. You have to have your baby. So we take care of that here. If you hear us give you direction, that's because there's really something going on. Most of the time we give suggestions or ask you questions, and if I tell you stand up right now, that's because I really mean that. I'm not trying to boss your labor around. I just want to help resolve an issue, okay? So we talked a little bit about maternal exhaustion already. Just to recap, this is a real medical condition when mom is no longer tolerating the labor. And sometimes it's unavoidable because of a funky position baby, or a slow, abnormally productive labor. But sometimes it's things you can prevent by not staying up all night timing contractions, and staying in bed and sleeping if you can when it's that early labor, staying well hydrated and staying well fed, and really taking excellent care of yourself at the end. Although these complications are very rare, it's important that we talk and discuss these different options, the different outcomes, and the different possibilities if a complication did arise. And now we get to move on to the fun part of checking the baby and assessing the baby's growth. And this young family, who is incredibly low risk and healthy, has gotten their green light to birth at the birth center anytime from now on. Put your fingers right here.
Yeah,
Have you felt baby's head down in there? Go rock back and forth.
Aww.
You feel that head?
Yeah.
Yeah, it's down in there.
Oh, yeah.
A hallmark of midwifery care is family involvement and partner involvement, and also student involvement. The midwives here at the Birth Center have a staff of 7 students that participate in all levels of client care as they become developmentally ready in their schooling. So we have junior students and senior students, and they rotate through various levels of education and hands-on care, hands-on help, so that they learn right along with the client as the midwife gives instruction, information, encouragement, and support throughout the process.